have 4 major clinical research trials going on in the Stanford Center for Lymphatic and Venous Disorders. I talked to you about bioimpedance analysis, that EKG-like machine that measures subtle amounts of fluid in the limb. We are using that technique to follow people that are at risk for lymphedema that haven't developed it, to determine how we can use preventive strategies to actually prevent the development of overt lymphedema. We are developing blood tests here at Stanford that will give us the tools one day to be able to make the diagnosis by a blood test, just like you get most of your diagnoses from a doctor, rather than waiting for the limb to blow up in size and say, oh, okay, you have it, nothing more to be done. But we need to do the molecular analysis with the help of patient volunteers who participate in these studies so that we can actually make that development that will one day be a tool not only to help the people that haven't developed it yet, but also the people that have it so that we can monitor their therapy and find new therapies that will be effective. We are translating some of the mouse work into patients and actually using some of the drug treatments that we've used successfully in the mice in patients, and we're actively looking for volunteers who want to participate in that. And the final work that I haven't discussed tonight is that I've done some work looking at the interplay between the person's metabolic status and their risk of developing lymphedema. And we have some early insights that are very useful, and I think we're going to be taking that work forward as well. I want to mention the Lymphatic Research Foundation, which any of you that have lymphedema or are interested in it should know about this organization. I'm very privileged to serve as the chair of the Scientific Advisory Board of the Lymphatic Research Foundation. I think they are the entity in the world that is doing the most to move research forward and find new answers for really troubling questions. I want you to know that I'm very proud of the fact that 4 years ago I was able to institute a Gordon Conference on the lymphatic system. This is the most preeminent research conference series in the world. There are about 250 of them that recur either annually or biennially, and we have now had 3 successful such conferences. The 4th will occur in 2010 in Italy. And I think this offers real promise for patients that scientists are getting together and actively deliberating about cutting-edge research as it might affect the lymphatic system. I want to emphasize the fact that through the Lymphatic Research Foundation, we have a peer-reviewed index journal called Lymphatic Research and Biology that provides an avenue for scientists to communicate with one another in writing about their research. I'm very privileged to serve as the editor-in-chief of this journal, which is now going into its 8th year of publication history. So with that, I want to thank you very much for your attention, and it's time for questions or comments. Debulking sometimes will keep company with the liposuction. Sometimes it is the primary surgery that's indicated. And the debulking, when we do it in a limb, it's because of that cellular overgrowth that thickens the skin. Sometimes we'll thicken all layers of the limb to the point that there's nothing that can be done mechanically with the limb because it's so chock full of cells and mass. Debulking surgery in general will only be safe and workable when adequate compression can be applied to the post-surgical region of the body afterwards. That's what would make debulking of the abdomen very dangerous, because it's very hard to apply adequate compression. I am very much an advocate of debulking in the right circumstances, and we send patients for this, but it's going to be really a minority of patients. And I would be very careful in the trunk portion of the body. The simple answer is yes, probably yes. Let me first talk about the statistics about the lymph node sampling. We really divide the world into 2 broad categories when it comes to breast cancer. We talk about the sentinel node technique, which allows us to sample up to 4 lymph nodes from the axilla. 4 or less equals a sentinel node technique. Anything more than 4 represents an axillary clearance of some degree. People that have sentinel node technique alone have about a 6% aggregate risk of developing lymphedema. People that have the full axillary technique have about a 25% risk. So just having a sentinel node technique already reduces your risk by 75%. But I would have to say that somebody who had a sentinel node technique and carries a diagnosis of primary lymphedema, probably that would be a more substantial number. Probably not as high as 25%, but somewhere in between. So you pretty much add together the risks or subtract them as the case may be. No, if lymphedema is present biologically, however it gets there, and it has, in the case that we've been studying, a significant inflammatory component, which we see pretty universally, what we are doing is treating the inflammatory component to break the cycle that creates in terms of perpetuating the lymphedema. We basically cut that off so that the lymph system can use its own healing strategies to try to restore its own function. And it doesn't really matter whether the damage is surgical, radiation, the types of nodes or the location of the nodes. All of that would be less important than the fact that the lymphedema be established for that particular aspect of what I talked about this evening. The drug would be able to allow the body's systemic features overcome the regional problem. There is clear body of evidence to show us that when that kind of massage is done by a properly trained individual who knows the directionality and the degree of pressure and all of the details mechanically about how to do it, there's no question but that lymph flow increases. And you can look at a limb that's swollen and watch it decompress under the impact of the technique. The difficulty resides in how well the therapist's expertise is transmitted and translates into the patient's ability to do self-management. In many cases, it may not be optimally helpful because it's not done completely correctly, but if the touch is incorrect, it could actually be an exacerbating feature. What I mean by that is that the technique is based on the following principle. If you put just enough pressure on the skin to open the lymphatic capillaries so that they're maximally prepared to receive fluid, but not so much that you stimulate an increase in blood flow to the skin, which will increase the amount of lymph formed, then the net flow of lymph will be in the right direction. If you're using too much pressure and you actually increase capillary skin blood flow, you will actually have potentially either a neutral effect or a deleterious effect. So everything hinges on how well trained the individual is to do it properly. But if you're doing it and you see that if anything it's keeping things stable and it's not making anything worse, and you have the time and the inclination to do it, it's probably a good thing to do. We don't lean on people to do it because we'd rather not have it done improperly than insist on it being done. The garment is the mainstay of successful lymphedema therapy. If you've had an edematous limb and gone through a course of therapy that ended up in the application of a garment, that garment is probably necessary. The thing to be worked out over time is how necessary is it? Do you really need it 18 waking hours a day? Do you only need it during certain activities? Do you only need it at certain times of year? All of these can be worked out a little bit by trial and error. I will preempt a question that may come up and say that one of the situations in which we think there's an increased likelihood that lymphedema will appear is doing anything at just existing at high altitude, let's say above 5,000 feet.